This is the first one. A 36-year-old female comes in surgical OPD with a lesion on the left breast. Now, a young female or middle-aged female having this kind of a redness erythematous patch on the nipple. Which of the following statement is true about this condition? Now, this image could be eczema, could be Paget's, but question of course is based on Paget's. Paget's disease, so which of the following is true? This is usually associated with underlying breast cancer. Von Neuss score is used for its treatment. Underlying lobular cancer is a common finding, usually bilateral. The only true statement is A. This is usually associated with underlying breast cancer. The underlying breast cancer you get in more than 90%, and in 50% you find a lump in the breast. In remaining you find just carcinoma in situ. And invariably this is ductal cancer. This condition is not found with lobular cancer. Paget's is not found with lobular, only found with ductal. And Von Neuss score is not used for Paget's, it's used for ductal carcinoma in situ. Based on the margin you have taken, the size and the grade. And then you decide whether further radio should be given or not, even chemo or etc. So mainly radio. So Von Neuss score is for carcinoma in situ, and Paget's is usually unilateral. This is how you differentiate from eczema. Paget's will start from center and go towards periphery, while eczema will go from skin to nipple side. And secondly, eczema is bilateral, Paget's is unilateral. And then you can do a scraping or punch biopsy, which will show you Paget's cells. Always rule out underlying cancer. Paget's is equivalent to carcinoma in situ, but isolated Paget's very rarely you get. Normally underlying cancer is there, so you treat according to underlying cancer stage. Usually they are CK7 positive. So these are the common finding feature of Paget's. A of course is the right statement. Which of the following is not a contraindication for payer for hydatid disease? Hydatid disease usually treated, nowadays treated by payer, but sometimes we do surgery as well. What are the contraindications? First of all, very superficial, not a contraindication, very superficial located, cyst with multiple internal septal division, cyst communicating with biliary tree, bone cyst. Site-wise, only lung cyst and brain cyst are contraindication. No other site is contraindication for payer. What is payer? Payer is percutaneous aspiration. First you put a needle in hydatid cyst, you aspirate, injection of sclerosing agent and re-aspiration. What sclerosing agent you use? We can use many. But 20% hypertonic saline is considered best and safest, or cetrimide. So you see, you put a needle, you aspirate, now you have emptied the cyst, now you inject the sclerosing agent and finally re-aspirate. The efficacy is 75%. Albendazole normal dose is 10 mg per kg, at least 2 weeks prior to payer should be given. Hypertonic saline is the best scolicidal agent. Contact time 6 minutes. And it's safest also. You see, in the past, formalin and so many things were used. Suppose there's cystobiliary communication. The same substance I'm using, sclerosing agent, through the biliary tree will go to the GIT. And 2 deaths were reported in Australia with the use of formaldehyde and all those things due to biliary atresia. Once we inject this, it will go through biliary tree and will cause damage to biliary tree, and patient died. So those are not used anymore. 2 safe are only cetrimide and hypertonic saline. Though chlorhexidine, alcohol, povidone iodine is used if we are sure there's no cystobiliary communication. But hypertonic saline and cetrimide even can be used if there's a communication, they don't damage the biliary tree. So it's not indicated, I'm saying, in cystobiliary communication, but it is safe. And the contraindications are very superficial, which is prone to rupture. Superficial means very prone to rupture, while like thin wall covering, not accessible. Internal septations like Harvey type 3, dead or inactive. Type 5, Harvey type 5 is a dead cyst, calcified, you don't have to do anything. Cystobiliary communication, lung and brain cyst. These are the contraindication for payer. Site-wise, no other contraindication is there. House-shaped Romberg sign is seen in. This is a sign of obturator hernia. When you internally rotate the thigh, so the obturator nerve has a branch called geniculate nerve which goes to knee. So if you internally rotate the thigh with slight adduction and extension of the hip, patient may have pain in the medial aspect of thigh which reaches up to the knee due to geniculate branch. This is called house-shaped Romberg sign. It has two signs, obturator hernia, house-shaped Romberg and Harrington-Kiff. Let's understand obturator hernia. You see, it is coming through obturator foramen. So in between the membrane and the pubic ramus, superior pubic ramus here. And when the hernia comes out, this will be like this is a pectineus cut muscle. Suppose it's intact. So the hernia will be behind the pectineus. Very much at the site of femoral hernia only. But femoral hernia is coming through the femoral ring above the muscle. It is deep to the muscle. Which muscle? Pectineus. So obturator. This is mainly seen in old age and females. So this is called little old lady hernia. Another name for obturator hernia. Coming from obturator canal, as you know, between the obturator membrane and the pubic ramus, here, here and here. And obstruction is very common, especially rectors. Rector means the bowel wall is getting obstructed partially, not circumferentially, only partial obstruction. Rector is very common in femoral and even more common in obturator. And femoral triangle pi swelling hogi, but below the pectineus. Now the two sign, one is house-shaped Romberg sign. When you internally rotate the thigh, there is a pain radiating to knee. And second is Huntington-Kiff sign, which is loss of adductor reflex. This is more specific. So these two signs you get in obturator hernia, house-shaped Romberg sign and Huntington-Kiff sign. Hand hygiene is indicated in all except. There was a question, now basic sciences questions are more commonly asked. In regular batch, I discuss GIT in detail, almost complete GIT takes about 4 days. Is this batch, this year I did not discuss liver gallbladder, but I used to discuss complete GIT in 4 days. So GIT I discuss in detail, in very extensive, complete everything I cover. So normally I don't keep too many questions from GIT in grand test, etc. because already that we have covered in detail. So I keep more questions from basic sciences, which is becoming more important now. So hand hygiene is indicated in all except when hand is visibly soiled, after bare-handed touching of contaminated instrument, before and after. This was one question in All India, I think 2 years back. That which of the following is the indication of hand hygiene? One option was before and after touching, not treating, touching any patient. And before entering, this is wrong. This is no indication. If you are not going to touch anything, you need not do hand hygiene. So hand hygiene is indicated as before touching patient, after touching patient. Then any aseptic technique you are going to do, like catheterization, like even IV cannula you are going to insert, ICD you are going to do before moving from work on soiled body side. So whenever you are near the soiled body or you touch something, then and contact with blood, body fluids and contaminated surface, and finally after you remove the gloves. So these are the indications where hand hygiene has to be followed. Otherwise there's no need of hand hygiene. Like you are going to OT and you are not going to supposed to touch anything, you can very well keep your hand in your pockets and there's no need for hand hygiene. False statement about Lemieux syndrome is, Lemieux syndrome is not a new entity, it's a very old entity. Only thing that has changed is it has become less common and the mortality has gone down drastically due to the availability of antibiotics. Lemieux syndrome, the mortality was 95% earlier, now it is 15%. So caused by Fusobacterium is correct. Commonly seen healthy teenager, young adult, correct. The infection originates in throat and spreads via septic thrombolytitis. This is correct. This is the most common route, tonsillar fossa through the tonsillar vein and finally to internal jugular. The embolus is in the internal jugular vein, thrombus rather, not in subclavian vein between first rib and clavicle. This is called Pigeon-Shorter syndrome. a part of thoracic outlet obstruction. So here the embolus is in the internal jugular vein, coming usually from the tonsillar fossa. Very dangerous condition, can cause septicemia, can cause embolus to other areas, or it can come from other areas as well. While the obstruction here between the first rib and clavicle, the subclavian vein gets compressed. This is called Paget-Shorter syndrome, a part of thoracic outlet syndrome, having bluish discoloration, pain, edema. So this is Paget-Shorter syndrome, while Lemieux syndrome is thrombus in the internal jugular vein, not in subclavian vein. Okay. Most common nerve injured in lithotomy position. Again, surgical positions, you do get question. In common peroneal nerve, saphenous nerve, femoral nerve, obturator nerve. All nerve may get injured in lithotomy. Saphenous nerve just at the lateral malleolar side, peroneal nerve at the. This also you read in orthopedics and many places. Like when you apply cast and all those, the nerve gets injured here along the, just by the side of neck or fibula. Femoral nerve, obturator nerve, of course they can get injured here. Most common is peroneal, by the stirrups or by the support to the knee. So in lithotomy, one should be very, very cautious about the pressure on the lateral aspect of knee. Patient can have peroneal nerve injury. This is the most common nerve injured in lithotomy position. Carrel's triangle is used for the anastomosis of. This is a All India question already asked once. Alexis Carrel was the first surgeon who got Nobel Prize in 1912. Second surgeon. First surgeon was Theodore Cocker, Emile Theodore Cocker, Kocher, Cocker artery fossa wala Cocker. So Theodore Cocker was the first surgeon. He got Nobel Prize for thyroid surgery in 1909, and he is called father of thyroid surgery. Like Bessani is father of hernia surgery. Carrel is father of vascular surgery. Vascular surgery. And Alexis Carrel developed a technique of vessel anastomosis, where he simply converted a vessel into a triangle. One suture here, one here, one here. You pull, convert in triangle. Now you can very well anastomose one wall here with the other two vessel. Rather than circular anastomosis, convert in a triangle. So it becomes equidistant sutures and equidistant angles, and everything becomes much easier. So like this. So this is the technique of doing make a triangle of vessel anastomosis devised by Carrel. 1912 he got Nobel Prize, almost 110 years ago. There's one more Carrel contribution than renal transplant. That is Carrel's patch. So if this is the aorta, this is the renal artery, let's say this is the right kidney and this is the left kidney. If I'm doing live donor transplant, I'll cut artery here. And then we do anastomosis with end to end. I mean, this internal iliac will be anastomosed to renal artery, something like this. This is how you do live donor transplant. But in cadaver, because the renal artery stricture stenosis is common. But in cadaver, we don't do like this. In cadaver, you can do Carrel's patch. Carrel's patch means you can take a patch of aorta. So now when I take the renal artery from the cadaver, this end is much bigger here. This is Carrel's patch. You see here. So I can very well do end to side anastomosis, because now my opening anastomosis is quite big. So this is the cadaver transplant where I can do end to side. Had it been live donor transplant, then my anastomosis will be end to end with internal iliac. Because of the bigger size diameter I need, stricture end to end will give bigger diameter anastomosis, end to side will give smaller. So here we get bigger diameter by bigger orifice of anastomosis by Carrel's patch. That was another contribution. All this given 110 years, 115 years ago, still being practiced. So Carrel's triangle is used for vessel anastomosis. Identify the image. And this is a simple image. This is a fish hook appearance you see in retrocaval ureter. Fish hook appearance. Retrocaval ureter is a condition where the vena cava is anterior. Ureter is going behind the vena cava. It's an abnormality, congenital abnormality of vena cava, not ureter. Rather than subcardinal, rather than supracardinal vein, vena cava develops from subcardinal vein. So this you see here, the ureter encircling the vena cava. If the high type, then you get a sickle-shaped image, and if it is a low type, then you get a fish-hook appearance. And the treatment, of course, would be cut the ureter, bring it anterior to the anastomosis. This fish-hook appearance is a classical retrocaval ureter, common in males. Treatment is present with hydronephrosis obstruction, and it's a congenital anomaly of vena cava where it develops some anterior subcardinal vein rather than posterior. This is the abnormality, this is normal, posterior supracardinal vein. A perforated peptic ulcer situated on the posterior surface of stomach, it perforates. In which space the content will go out of these four? The answer is lesser sac, posterior. This lesser sac is same as omental bursa. They both communicate. So you see, this is a lateral view. This is the vertebra. This is the duodenum. I am using word D for duodenum here, violet color, it's mentioned. This is pancreas mentioned. This is liver. This is stomach mentioned. This is transverse colon. This is the small intestine. Now I am using green color for lesser omentum. This is lesser omentum, the green structure. I am using blue color for greater omentum. This is the greater omentum. And I am using red color for transverse mesocolon. This is transverse mesocolon. Here. So the complete greater sac, pink area is greater sac. Complete blue area is lesser sac. Pink area and blue. Greater sac means abdominal cavity here. So if the stomach perforates anteriorly, or the decolon or small intestine or duodenum, anything perforates, the content will go into greater sac, causing peritonitis. But if the content go posteriorly from the stomach, blue space, this space, this space, this is lesser sac. So posterior gastric content goes in lesser sac, and this part here within the greater omentum is called omental bursa, which of course communicates with lesser sac. So omental bursa and lesser sac are same, but the lesser sac content can go into greater sac through this hole called foramen of Winslow here, or epiplug foramen. So even posterior duodenal gastric perforation will cause peritonitis. So whether it perforates here, it will cause peritonitis. Whether it perforates here, it will cause peritonitis, because both spaces are connected by foramen of Winslow. But a duodenum posterior perforation here will cause bleeding, first part duodenum. Behind that we have gastroduodenal artery, so it causes bleeding. So in this Morrison pouch is the right subhepatic space or hepatorenal space, which is the most dependent part when the person is supine. Most dependent part when the person is erect is pouch of Douglas. In supine Morrison pouch, right subhepatic space. So, but the content of the posterior gastric perforation will go into this space, blue space, which is lesser sac continuous with omental bursa. Okay. Yeah, this is a very new drug approved only very recently, I think last year only. So this question can come in PGI kind of paper. It's not new drugs they do ask. So the treatment of colon cancer is surgery. Chemo and immunotherapy is only for adjuvant, neoadjuvant and advanced cases. So certain monoclonal antibody approved for colon cancer. One is cetuximab, cetuximab, CETUXIMAB. This acts through epidermal growth factor and it is only approved for wild RAS positive cancer. So RAS is present in chromosome 12p, not RAS, wild RAS only. Second is panitumumab, panitumumab, panitumumab. It also acts to abdominal growth factor. Third is bevacizumab. I guess you know it's approved for vascular endothelial growth factor, VEGF, bevacizumab. And recently, FDA has approved nivolumab and ipilimumab for HCC as well. This is only approved for MSIH or DMMR. What is this? Already, I'm sure you must be aware, HNPCC, hereditary non-polypous chronic cancer, acting through MSI, microsatellite instability, which acts through MMR, mismatch repair gene. Now, MSI has three variants, H, L, and S. Heavy, high, low, and stable. High has the best prognosis. So this is only approved for MSI high type, MSIH, or DMMR का मतलब deficient MMR. So MSIH or deficient MMR, it is approved only for this. Okay? And this has better prognosis also. Which of the following is definitive indication of adjuvant chemotherapy in oral cavity cancer? Node positive, residual disease, T3 stage, penile invasion. Out of all are indication for radiotherapy. But out of these, only this is the indication for chemotherapy, definite indication. Chemotherapy definite indications are two. In the node, you have extracapsular extension. And second is residual disease. So you see, stage T1, clear margin, more than 5 millimeter, no lymphovascular invasion, no microscopic muscle invasion. This is low risk, only surgery. T3, T4, close margin resection, less than 5 millimeter, lymphovascular invasion, perineural invasion, posterior node is for post-operative radiotherapy also, adjuvant radio. While positive margin and extracapsular extension is the indication for chemo. Now you post-operative chemo and radio. Now you add chemo also. So this is a definite indication for chemotherapy in head and neck cancer. Identify the hernia surgery. Well, if you see, this black line is inguinal ligament. Rather, this line is, and this is the conjoint tendon. So in first layer, you are only stitching the fascia transversalis one above the other. I am not approximating conjoint tendon with inguinal ligament. I am only stitching fascia. Then in the next layer, I am approximating conjoint tendon with inguinal ligament. What is this surgery? If I only show you this, no double breasting, then this becomes Bassini, where fascia and conjoint tendon together are stitched to inguinal ligament only. But this is double breasting of fascia transversalis followed by conjoint tendon stitching to inguinal ligament. This is Schulteis. Both are examples of herniorrhaphy. So in Bassini's, conjoint tendon directly stitched to inguinal ligament, while in Schulteis, first you do double breasting of fascia transversalis, you overlap one on the other fascia transversalis, and then you stitch conjoint tendon with inguinal ligament. What is darning? Darning को हिंदी में कहते हैं रफू करना. Raffu. You simply use a non-absorbable suture and apply crisscross and make a mesh. And finally, Macway is really done for inguinal morphofemoral hernia. You stitch this to the iliopubic tract. So Schulteis and Bassini's are the two herniorrhaphy, and this is Schulteis, where you double breast the fascia first and then stitch inguinal ligament with conjoint tendon. So this is the Schulteis repair, where first you stitch the fascia only, double breast it, and this is the Bassini, where you simply stitch fascia and conjoint tendon directly to the inguinal ligament without double breasting the fascia.